Thanks, Vivash, and good morning to you all. What I want to talk today, it's all about mental health. So I want to give you an overview of the type of limitations that are there in mental health, how we manage mental health problems, and how we diagnose problems. What are at a systemic level? I'll give you an overview of limitations and then outline some digital solutions to address a few key areas. Just as a background introduction, so I'm a computer science engineer by training, but I've spent last 10 years working in mental health. So these days I see myself more as a mental health researcher than a computer science engineer. So most of the work we do, it's very much at the applied end. We create practical mental health services using technology. So we take mature technologies and we integrate them with clinical care models to address the unmet need, and we evaluate and then we deploy that into standard service. So we sort of see ourselves as a bridge between the methodologists and clinical researchers to translate what's happening in the labs here or in the mHealth space, and what's identified as need in mental health space, and how do we bring those two together. So we are quite multidisciplinary and also working with a lot of people internationally. So I started working with Susan and Vic Strecker 2 years ago around MRT, and that's how the connection developed. And then some acknowledgements. So we are funded heavily by health services in Australia, especially the South Australian Department of Health. They act as a test bed for a lot of the work we do, and they're also co-investing in our research program. And there are a range of other funding programs, both competitive and industry sources we receive. So let me start with the problem. So mental health problems are very common. How common they're in Australia, 1 in 5 have mental health problems. In Singapore, it's a bit better, 1 in 7, but across the world, it's 1 in 4. Anyone can get these. I presume you recognize these faces. All of these people have been affected by mental health problems at some stage. So looks can be deceiving when it comes to mental health. It's not physically visible who has it, who doesn't. Regarding the mental health problems, there are a range of types. The common ones are depression and anxiety. That's the main problem that affects a large number of people. The good thing about it is it's curable. We can get therapy, and therapy is effective, and most people do recover. And the ones who don't get treated early on don't recover, and they need ongoing support. So the early intervention is key there. Then the other type of mental illnesses that's not so common, but a very expensive one, is schizophrenia and bipolar, these psychotic illnesses. They affect around 2 to 3% of the population, but they're more expensive to manage because the symptoms persist. They keep coming back, so you need ongoing care. And medications are usually effective to manage those, but medications can have side effects as well. So there is a trade-off between when to medicate and when to take them off. There are other disorders like eating disorders and substance abuse and so on. I'm going to focus on these two categories because this is where we spend most of the mental health budget. So in Australia, we spend 7% of health budget on these, managing these depression, anxiety, and psychotic disorders. 60% of that is spent on hospital care, and 40% is spent on providing therapy. Therapy is mainly for depression, anxiety, and hospital care. You provide that when patients relapse, which is mainly for people with schizophrenia. So what's the problem here? In the last 10 years, in Australia at least, The funding for mental health has actually increased by almost fourfold, but the outcomes have not improved. So let's look at the depression, anxiety. We still have 1 in 2 who do not receive treatment, even though we have put in more resources. So we have more psychologists, more GPs. GPs are being funded more to diagnose people, but despite that, problems are there. That's partly why that's happening. Diagnosis is a challenge. People don't get diagnosed quickly. Access to therapy is another challenge. The traditional way of delivering therapy in clinic, that doesn't work well for everyone, so people don't engage with the treatments. And then there's a third problem which has not at all been addressed for a long time. It's engagement with therapy. It's one thing to improve access to therapy. That's a bit like improving access to medications, making it easy to pick up scripts. And to benefit from therapy, you have to actually practice those, and the engagement rates are very poor. People don't, for various reasons, and I'll come to that later. And then at the schizophrenia bipolar end, which affects a small number of people, so we have spent a lot of money to manage them better in the community. So there are case management services now, and there's been more and more case management programs. However, the relapse rates are actually going up. So in fact, according to the number there, I didn't took out the number, around 60% of patients relapse still, and the demand on hospitalization is increasing. And so why is this happening? This is a coordination challenge. So we have these case managers, but the case management model is patchy. They can only see patients at a fixed 3 monthly intervals, and the coverage is only for a small group of patients. So they don't have means to identify signs of relapse and initiate interventions ahead of time. Now, what are these signs of relapse? It's symptoms, and these symptoms are actually manifesting at any time when in between those appointments. So there is no means now to pick those symptoms up. The other sign of relapse is more at a systemic level. If a patient stops taking medication, it means two things. One, they might be doing well, or equally they might be getting worse. So then that doesn't get checked. So some of these things, like checking medications, that's something that could be easily done without mHealth because the data already exists in health service, but systems and decision tools don't exist. And the other thing, like monitoring symptoms, the technologies and the data doesn't exist in health services. How to collect that continuous data, continuous symptoms, how do we bring that data in, how do we feed that in? Those are the challenges there. So to recap, the three major challenges I see in mental health are: one, the diagnosis challenge. The mental health professionals struggle to identify problems accurately and earlier because the symptoms are hard to diagnose. Second, the access and engagement with therapy, that's another challenge. And the third challenge is how to help case managers intervene early. How can we create systems that will help them pick up the signals of relapse and initiate interventions? So I'll go through each of these a bit more in detail and outline some of the work we have done so far in this space as well. So to start with the diagnosis problem, I have diabetes here as an example because it's a lot easier to explain the diagnosis problem we face in mental health by using diabetes as an example. At the moment, there is no simple, easy way to diagnose mental illnesses. There is no biomarker. Despite decades of genetics and neuroscience research, people haven't come up with simple tests. So what do I mean by that? Take diabetes. So you have a simple test. You could do a blood glucose test, and if it's above or below 7 millimolecule blood glucose levels, you can rule in or rule out if someone's diabetic or not. Equally, you can use the blood glucose. You can monitor blood glucose continuously through devices in an objective way. And based on that, you can adjust treatments. You can triage different types of treatments. So you can start with behavioral interventions. If that's not working, lifestyle modification is not working, you can go into insulin, so you can step up, step down. So there is a simple indicator that the diabetes sector, diabetes care sector can use to optimize diagnosis and management. But mental health, there is no such thing in mental health. Instead, how do we diagnose symptoms? So what are these symptoms? The symptoms are things like poor mood. You're not able to feel good, or feeling consistently low. Or it could be hallucinations, which are like maladaptive thoughts. Or it could be behavioral symptoms, where someone's avoiding people, they are spending more time sleeping. So these are the type of symptoms which we can't pick up through some test. And so the only way we can pick these up at the moment is through observations. And that's the paradigm health professionals use. And as we know, that is observation-based diagnosis is flawed. In fact, studies have shown even the well-trained GPs can't pick up depressed patients half the time, because it's easy to conceal these symptoms. So there is that challenge. So either we have to come up with a blood glucose test equivalent biological test, or we have to get better at observation to diagnose this better. And by observation, I mean we have to be able to observe subtle changes in people's behaviors, their thoughts, their emotions, in a granular, continuous way in real world. And this is where the digital technologies come in. So the means we have to collect this data is only through digital. There's no other way. What do I mean by that? These days, the technology permeates all aspects of everyday life. And technology, I mean, not just smartphone, just the digital lives. So we leave behind digital traces as a byproduct of everyday living. So you have your phone with you all the time, and so the interactions you do on the phone either are mimicking the behavior you're undertaking in real world, or you're actually interacting within the phones, or they're capturing and they're acting as a window for the behaviors. There are smart devices, there are gadgets, and then there are digital traces that exist that you don't even know that is being collected in Internet of Things, the sensors that are embedded in living environments. So the concept of digital footprints it's quite ill-defined, because it's quite vague at this stage. There are several challenges too. The major challenges are this data sits in private sector. It doesn't sit with health services. It's controlled by industries, and that opens up another challenge on ownership, access, transparency of use of this data. These are challenges. The second challenge is also in the analysis phase. This data is not collected for health purposes. It's collected for something else, for some other business, for providing some other service. So we have to repurpose this data for health. So that opens up a whole new array of challenges for data analysis. And the regulatory aspect also, if it was health data, there would have been good, clear processes for us. If it was health data owned by government, to access the data, no matter how many hurdles we might face, there would be a clear process, but there is no clear process about how to access this data. Even consumers or people who have their own data, they can't access this easily. So there is a lot of unknowns. But it has potential. There are patterns in these digital trails that relate to our behaviors or symptoms. So we have been looking at two types of digital footprints. The first one is the phone and the smartphones and the apps, using apps to collect smartphone data. Because the signals in mobile phone, the keyboard strokes, the movement patterns, and then of course there are challenges in collecting some of these, like the images and speech. They all have features that are related to some aspects of mental health. To illustrate this, like with speech, it's not speech and image. When we say this, often it gets criticized that we are interfering with privacy, and that's to some extent it is. We don't actually need to look at content, but we need to look at the non-personal features in these images and speech. Like with the images, it's not the three-dimensional spatial features of someone's face, how those are evolving over time, if we are sampling them through phones, could give some indication. Now with the speech, so I have here a clip that I want to play. This is Heath Ledger with. Turn this on.
It's not unnecessary fighting. They're fighting for a reason. They're fighting for land, love, for a hope.
When he was young.
You know, any hope is good hope, and that's what Connor's always got in the back of his mind.
And here is another clip when he was 28 years old. Okay, something went wrong. You should have been able to hear that. Now, the differences between I'll put this presentation now online, and you can see this later. The second one was taken just a few days before Heath Ledger committed suicide. So we have several trained experts, psychiatrists, have been blind tested to. So this is not published, to check which one was taken before suicide and which one was taken after, and they can't tell the difference. But if you, the field of speech processing has a lot of methods which can extract features within the speech. These are features that are not audible to human ears, and these features, like the tone or non-audible tones, and these features relate to distress levels and severity of suicide risk. So that's possible. It's possible to derive mental health related insights from this type of data. Now this is not my area of research, extracting features from speech or extracting features from image. What's my area is to, and this is an area that's been the field has been working on this for the last 10, 20 years. These algorithms are not new. What's new is that with the mobile phone, which is with the users, people interact with their phone around 100 times a day. They are touching and swiping their phone around 1,000 times. So there's opportunity for us to now sample them in a continuous manner and in a granular way, and plug into these algorithms that are already there. And with the capabilities the phones has to compute on the device itself, we might be able to calculate some low-level features. So this is an area we have been working on. So we're creating. We have developed an early version of smartphone app that can collect all these features, and we have deployed these in some prospective cohort studies, psychiatric cohort studies. A cohort study in Germany and a cohort study in US. And so we're collecting the smartphone data parallel to the gold standard measures they're collecting, and eventually we want to untangle the relationships between these two. There are a lot of challenges with collecting this. There's a privacy challenge, but there are technical challenges as well. But the field is not mature yet, but we're heading there. The second one I want to talk to you about is activity trackers and wearables. Now, the proliferation of these devices is pretty high. I presume most of you have used these. How many have used these devices? Quite a few. Do you feel you became active as a result of these? No, I don't think so. In fact, the trials have also shown just the activity trackers don't make people active because self-monitoring alone is not a big incentive. However, they have become very popular, not because of health, more as a fashion marketing gadget. And that tells something about health as well. If you try to sell health products, people won't adopt them. But if you frame it in terms of what they actually value, then the adoption rates go up. Nonetheless, the adoption rates are pretty high. So we wanted to explore because these devices are always with people, they might not be accurate in terms of measuring exact step count, but they are actually sampling consistently over time how your steps are changing. So we wanted to see if there are behavioral patterns within these that are related to mental health. But more importantly, we wanted to check if people with mental illnesses are willing to download and use these and share this data for monitoring purposes. So we did a small study. We recruited around 120 young adults from reachout.com. Reachout is a popular online mental health service for young Australians. It has around 1 million visitors visiting every year, and it's a go-to place for 13 to 24-year-olds when they have mental health problems. So we screened their baseline mental health, and then we asked them to use one of the 42 different, from one of the 42 possible activity trackers, both wearable ones as well as smartphone apps, that off-the-shelf devices. And they had to authorize access to data for monitoring purposes. So there's a paper there which describes what the details of the protocol and results. So we found half the people were willing to use. That's pretty good, because the other half, when we did some qualitative insights, didn't use because they were having difficulties with downloading and setting up accounts. Their mental health problems were most likely very severe. The data itself is, we asked them to use it for 6 months. Even though this is an unobtrusive device which doesn't require them to do anything, they're still missing data, and the missingness is not, it's uneven, it's not planned missing, so that creates a lot of challenges. So we did some preliminary correlational type analysis, so we found some interesting insights. The volatility patterns, or the entropy in daily activity steps, were correlating with the severity of depression. So in other words, the more volatile or the more random your activity patterns were, the more depressed you were. Now, what does that mean? If you are not depressed, if you have a healthy life, you have a typical routine. You go to work some days, and then you might go to a gym, you might go weekends, you might do some activities, and so you have your own cycle of life. And that cycle repeats itself over time. And that's a marker of well-functioning life. Now, when you're depressed, such markers don't exist. In other words, you're not following particular habits or patterns. So if you're depressed, those patterns disappear. And so in the data, that appears as more entropic signal. In other words, we don't see those repeating patterns. So that this would need more validation and replication studies to confirm what are the thresholds at which it could be clinically useful to say someone is depressed and need help. So we're now looking at accessing large data sets. One particular data set we're looking at is the UK Biobank. That data set is it's sampled in a different ways, but we are trying to replicate these analysis there. And the translational implications are huge if we find signals. One of the big problems with mental health is stigma with diagnosis, especially workplace-based mental health interventions. No one takes them up. When an employer comes and asks, we are offering you mental health intervention, everyone walks away from those for good reasons. This is suspicious. But the adoption of physical activity interventions is great in workplace. So, and as part of that, they do offer them all these wearable trackers. So could we use the workplace physical activity intervention to get a better understanding of the real mental health problem and the burnouts that's happening in that workplace? So there's a secondary means here to find that out, but there are also ethical challenges how we use that approach, how we communicate and how we sell that approach. So that's an overview of the diagnosis problem. So now I'll move to the next topic, which is about access, improving access to psychological interventions, or CBT. The recommended gold standard treatment for mild to moderate depression, which is what most people experience, which is the one I said earlier, 1 in 4 experience or 1 in 5 in Australia. For that, cognitive behavioral therapy is the best treatment, and that's the first line of treatment that's been adopted by all major health organizations all over the world. However, access to those CBT is not that great. Now, I'm presuming everyone's familiar with CBTs to some extent. At the simplest level, it's about through behavioral interventions, correcting your thought process and emotion and behavioral processes, as opposed to doing it through medications. There are a range of tools and processes that the therapist will use to take the patients through. So there are some interesting things. In Australia, the government invested in more therapists, so we had these various programs that improved access to psychologists. However, most patients don't like to go and make these appointments. There's stigma attached to it. So to overcome these problems, it's very clear you can start offering this therapy digitally. And that's something we also have done. There are a range of things we did in our own lab. So we set up telehealth services, set up phone-based services to offer therapy over phone. And even more recently, we set up a service to guide people to access apps as well, mental health apps. There are over 10,000 mental health apps out there now. And this is one of the products that came out, which is integrated in Reach Out service, reachout.com, under Tools and Apps section. It basically helps young people to it takes them through in a structured way which app is best suited for the symptoms they have. And these apps are vetted, and the content is kept up to date. So in a nutshell, I would say we have actually improved access, the delivery of therapy. We have made it accessible. Of course, there are still problems to be addressed, and it's not equal access everywhere, but it's not really a research question anymore to work out how do we improve access. It's because the internet interventions, there are a range of internet resources that anyone in the world can access, and they're not restricted to particular countries. While we have improved access, what we haven't done so well is improved engagement with therapy. Now, at a fundamental level, based on my understanding of how cognitive behavioral therapies work, there are two aspects that the patient needs to do. They have to do some form of self-monitoring. It could be monitoring their mood, or it could be monitoring their thoughts, and the actual content of monitoring will vary, but the process is they have to do that on a regular basis. And then there's another part where they have to reflect on what they have monitored and forward plan or change something based on what they have recorded. So these two things, the concept of needing to enter data and keep track of on a sustained way and process that and change your behavior, they're very burdensome, demanding tasks. They require time and energy, and which, if you are depressed and if you're anxious, you would have low motivation, and that's the last thing you want to do, is to sit there and monitor yourself. So there is that challenge where the therapy that works in concept doesn't actually work in the real world, because we don't have that support mechanisms. So the question is, how do we? So for me, the question to address is not so much can we improve access. It's more, can we help people practice what they have learned in therapy, or integrate what they have learned in therapy into daily life. And how do we do this? This is where smartphones and mHealth comes in. I see the phones as because they're with us all the time, they are like a personal assistant. Could we reposition our phone to become like an angel on the shoulder that's telling you what to do, or giving you the right support at the right time? And how do we do that? Now, everyone has a phone. Maybe not everyone has a smartphone. But still, and the therapists who do CBT could start sending messages in between clinics, but they don't do that. It's not a standard practice. They're not. Partly, we don't yet know how to do it, what to send, and at the other end, we also don't know how to. It's not reimbursed either, so therapists don't see it as it's seen as an extra work. So we did some work related to this in 2013. So we tested a text messaging protocol where the therapists, in this protocol, the therapists and patients at the end of an appointment would collaboratively decide the type of messages the patient would need to receive to do the activities that they have been asked to do at that session before they come back next. And they would schedule the timing in consultation, and all those messages would be scheduled to go. And we had this was integrated with an existing clinic. These were patients who would come to treatment with suicidal ideation, so they were really severe type patients. So the therapist would see these patients every 2 weeks over the phone. They would do brief CBT review and then plan, and then they would schedule these messages. We couldn't do a controlled RCT in this group because of the nature of the group we were dealing with. So we took a case-matched control and looked at some basic outcomes. In both groups, there was no difference in the symptom level changes, but there was some interesting secondary insights. The group that received these in-between session text messages was getting better, showing same level of improvement with one less session. In other words, they're getting better quicker. And this was not a fluke. We did qualitative interviews, and we confirmed that the patients would say these messages were giving them a sense of the therapist was there, pushing them to do the things, and that was motivating them. So this type of work motivated me then to go deeper into this. How do we use these messaging technology better in mental health? And this is around the time I met Vic Strecker, and through Vic also met Susan. And we did a study in Jewel Health, which is a company, well-being app company that Vic Strecker runs. So in this study, we wanted to we used micro-randomized trial in this, and Susan had designed this trial before I went to analyze and work with them on this. So I'll give a quick overview of this study. So in the primary question we wanted to ask was, if we prompt people with messages that are tailored to their context, and if we send those messages at convenient times throughout the day, are they more likely to engage in self-monitoring? Now, self-monitoring is a component of CBT. That's the type of thing that we want people to do in outside clinic. And we know people don't do, so we wanted to check are prompts actually persuasive, and micro-randomized trial is actually pretty good, designed to answer this question, do prompts actually work or not at the primary level, but then the secondary level to start looking at are these prompts effective over time, and how do these effects vary over, what's the best time to prompt, things like that. So I think given there's the interest in MRT, I'll quickly run through this study. So the app in which we tested, it's a well-being app. There's a whole range of well-being interventions in it. I won't go through that. The main thing is people must track their well-being on a few times a week at least, because the intervention is feedback intervention, and the more they track, the more personalized feedback they get. And also the concept of monitoring itself is an intervention, because when you're monitoring, so this is aimed at relatively healthy workforce population who experience day-to-day stress. They're not depressed, so this concept of self-monitoring is not so bad for them, as they're not reflecting on poor things at all. They're also reflecting on good things, and that can activate their sense of self. So to encourage them to prompt, to monitor the people, the app would send prompts, and there were some constraints on how these prompts are sent. So here are the type of constraints that were set in the app. Now these constraints were to ensure people were not sent prompts in inappropriate times, or that is that the prompts are not habituating them to avoid using the app altogether because the prompts are annoying them. So some of the constraints the app had was you don't send them more than one prompt a day, and you send prompts at these fixed 6 time points, which are like before work, during lunch break, and then at a few time points after work. Which these are the time points when office worker population is likely to be available at a population level, and we wouldn't interrupt, and we would interrupt them less on weekends. So we wouldn't interrupt them in weekend morning. And the other constraint was if this is more at a longitudinal level constraint. If people use apps in different rates, some use them every day, some use them a few times a week. So we take into account this natural rhythm of how you use the app, and accordingly adjust how many prompts you're going to receive over a longer period of time as well. So if you're a frequent user, you get more prompts, and if you're a less frequent user, you get less prompts. So there were all these intelligent policies built in. So with these constraints, we wanted to ask the question: should we prompt or not? Are the prompts effective? Are they encouraging them to monitor? How does this effect vary over time, and when is the best time to prompt? And the proximal outcome measure here was, did the user actually open the app and complete the self-monitoring within 24 hours? We chose 24 hours because the monitoring was for the whole day, so you would be entering data that was for that particular day, or in the 24-hour range. So this is the randomized protocol. So there were 3 types of randomizations that happened. So the day of the week was randomized, and within each day, when the chosen day, the time of the day was randomized, and at each chosen time there was another randomization: should we send or not send? So the trial was run with around 1,200 app users over 90 days. Now this is a good thing about these type of trials. If you design and embed them properly, you can run these pretty quick. And so all these people in the entire Joule app ecosystem went through this protocol. So it's not a traditional RCT in the sense you have to consent and recruit them. It's part of the product optimization design. And that even the clinical trial committees accepted that as a distinction from traditional RCTs, which is good because we want to be able to do these type of trials rapidly and learn and do the next MRT. So what did we learn? So all of these results are in that paper. So we did find that prompts are effective. The effect is small, so they do actually persuade people. And over time, the effect does drop. Engagement always drops over time, and with the prompts it does too, but it is likely the prompts are slightly attenuating the slope of that curve, but we didn't see any statistical significance there. And then weekends and midday weekends were like the best time to prompt. That's when we had found the most significant effect. So that gives an idea of how we can, using this type of experimental approach, how we can actually personalize and start developing more tailored interventions so that we are for people with depression and anxiety as well. So that's where we want to head next. And if we do those things, we can actually we can get one step closer to turning phone into a personal assistant that's prompting them, offering them the right support at the right time. Now another aspect we are working on, this is not so much on the monitoring, but it's more on the planning. So if you've done all this monitoring, then you need to synthesize all that information and forward plans. Say that's another aspect of CBT, and a specific component of CBT is behavioral activation, where you get people to record all the activities they've done, then how their mood was with those activities, then they have to synthesize which activities were mood uplifting and schedule more of those over time. So it has this interview two aspects. You got to monitor, and then you have to filter out good things, and then you have to plan. And people are good at picking up extreme patterns, so they can pick up things that make them super happy and things that make them super bad. It's the things that make you slightly better, but we can't notice those. We are not conditioned to pick those up. But algorithms can pick up. If we can optimize the monitoring, and if we have the signals about the mood and activities, we can actually build recommendation algorithms that have picked up things that are gradually improving their mood at a small level, and we can nudge them. Why don't you try this? Why don't you do this instead of that? And the more they do those things, that actually then has a flow-on effect. It lifts their mood. So here we can, this is something we're planning to do with Susan's group to develop the recommendation algorithms. We have an app we just starting to pilot, and we want to go next step towards creating those recommendation algorithms. How are we going with time? I tend to keep going. 15 minutes, okay. Now I'll run to quickly to the last section of my talk. In this part, we are working with public mental health services, case management services. Here, our focus is it's not so much at a patient level, not creating apps for the patient, but creating systems and tools for case managers to provide better coverage for patients before the relapse occurs, or enhancing the capacity to pick up when patients about to relapse. And trigger those early interventions. In this project, so this is a project it's very translational. It's funded by the Australian Medical Research Futures Fund. So it's and the health services. The systems we're developing here are actually part of clinical service. They're not sitting outside the like they're not standalone clinical trials. So there are three objectives in this. In this, so we're using electronic health records first to identify our cohort. That's the case managed cohort. And then we're combining their EHR information with their personal data that comes from apps and wearables to create decision support tools. And we are feeding those decision support tools to case managers in clinical service model. And we're testing new service models through that process. So I'll take you through the different steps here. This is a project in South Australia. So the starting point is identifying our cohort. These are case-managed cohorts. So in South Australia, we worked with the Department of Health to set up a central warehouse that has all the case-managed patients. There are now 18,000 patients in this database. These are people who have either had an hospitalization for mental illnesses, or they are currently being case managed. So it's actually the most severe end of the cohort. We're probably missing some of the patients still who have schizophrenia who never had hospitalization, but we believe we're capturing around 70 to 80% of the population with severe mental illnesses in the state. And there are around 2,000 new patients coming in here. Now, the first thing we wanted to do, the first decision tool we wanted to develop was to monitor medication non-adherence, because that's something we could look at within health records itself. But the challenge in Australia is we have a two-tiered healthcare system. The state health services provide hospital care and outpatient care. Medication management is provided by the Commonwealth, which is our central federal government. And they use a different system to keep medication information, and these two don't talk to each other. So to address that problem, we developed a software called platform. It's called AI Squared platform. You can check this up on website. It's aisquared.co. There's a paper there that describes the process we had to go through to create this software. So what this software does is it automatically registers every patient who is on our warehouse, the case-managed patients, and it connects to the medication system. It pulls their medication information, and there's a decision tool like this, which what you see. These are all the claims records that are entered in that are coming from the claims database. We map them into clinically meaningful categories, like the medication types, the type of test, the type of reviews. And then we have algorithms there as well, which these are, at the moment, they're simple algorithms. They're guideline-based algorithms. So here you have patient who is on, I presume this is antipsychotics, which in Australia, they disperse them every 30 days. Here is a patient. This is actually a real patient's data. This patient hasn't picked up an appointment around this time, and then an alert is triggered. Another month has passed, they haven't picked up again, a red alert is triggered, and this actually goes to case managers. They obviously do something, and then the compliance has improved, so they picked up 2 scripts. So this, what we're doing here is, they're not quite fancy from an algorithm point of view, it's rules-based, but we are finding those time points when a case manager should provide coverage, and we're triggering that intervention on a needs basis. Yeah, so I'll come to that. So there are two different ways we are integrating this into clinical practice. In one model, these are the trials that are now underway. We send text messages to patients and their carers. In another model, we have a dashboard that feeds these alerts to the case managers. So they have, during the weekly meeting, they actually prioritize which patients they are going to discharge, which patients they're going to admit. So we're feeding in these red flag patients as well onto that weekly meeting. Yeah. So with the first trial, with the text messaging trial, it's a simple RCT trial. It's a very preliminary trial, so it's not the primary outcome there is does the message sent in response to alert increase patients' adherence to medications within the next 20-30 days? Do they end up picking up scripts? This study was actually designed even before I was familiar with MRT, so RCT is how we went with. Now, there's another reason why we're not going with MRT, because these alerts they're less frequent events. Most of the times patients are actually compliant. So unlike mHealth, you don't see these episodes appearing on days level. They occur on months level. At most, you'll get one a month. Now, the case manager's dashboard, that we are trialing in a different way. That's actually rolled out to the clinical services. Every case manager uses this dashboard for a period of 6 months. And we're evaluating, do these alerts help them prioritize caseload better? Are they making appointments with the patients who have a need on a needs basis? And the comparison is the case manager's work patterns 6 months before this intervention was. So it's like an interrupted time series analysis. So in both of these trials at the moment, what we are doing is checking, do these alerts improve management? Like, do they lead to patients being managed as they should be managed? And if we do find signal, it does, then obviously the next step is to check, does that better management lead to reduction in hospitalization? So we did actually do a simulation trial on, this was mainly to evaluate the quality of interventions that you provide in response to alerts. So we tested various scenarios where we had low quality and high quality interventions. And then we sort of wanted to understand what impact that would have on reducing hospitalization risk. And so the interventions had to be at least like medium quality for it to have value add on hospitalization reduction. And what is low and what is medium, that it's based on how care is currently provided there. Best quality is when everything is done according to the guideline. And medium is when there is some clinical discretion, and the practice variation means some people do follow guidelines, some don't. And the lowest quality is you just don't do anything, or you do and patients don't respond to it. The interesting thing about these is these are trials we would be doing at the database level. So there's large groups of patients. I see these as public health interventions. So with public health interventions that are slightly re-engineering the workflow and the work practice guided by these tools, and the impacts would be at the public health level. Are we reducing hospitalizations as a result of these systems? So that's the first relapse sign. The second relapse sign we want to look at, we want to track, is the symptoms itself. People with schizophrenia, bipolar, their symptoms are quite recurring, and these symptoms can manifest anytime. And the only way to find out that symptoms is actually observe these people. So at the moment, none of that information is collected. So we developed a smartphone platform to collect this information. So it pulls in range of sensor variables. It also does various EMAs. And there's a dashboard where all this information is made available to case managers. And so we are sort of looking at integrating this dashboard in clinical practice now. And in this type of information, we are not really changing the case management coverage, but we are checking, does this type of insight from real world, symptom insight from real world, does it lead to more personalized care if during the time of appointment they had this? The reason we are not using this to trigger interventions is because we don't yet know what is the correct threshold to trigger that. And this, whereas feeding it into existing case management appointment is a safe bet that leads to adoption, and when we have that adoption, we can start experimenting, analyzing the data to look at how do we manipulate the appointment patterns. So this is a 6 months trial that's currently underway. And so all patients in the clinic, so we randomly approach them, and half the random groups will be given the app, and case managers will be delivering care using data from this app for the half of the group. And the outcome here is the differences in quality of personalizations recorded in their clinical notes over a 6 months period between intervention and control group. And the actual outcome metric, it's captured by auditing the case notes. So we'll have these independent psychiatrists who are blinded to the trial. We'll look at case notes for both intervention group and control group, and they'll be looking at insights related to personalization based on certain criteria. Yeah. Yes. Yes. So does the case manager provide a more personalized care if they had insights into what was happening to the patient before the appointment? Insights collected through the app. Well, these are case-managed patients, so the treatments might be, there's a medication review, so they might change their medications, or they might offer them more psychosocial support, or they might discharge them even. Sometimes these people might be actually doing fine, and you don't need to provide case management coverage. Yes. Yes, yeah. So in the control group, all those intervention decisions are based on what the patient tells them at that appointment, or what they learn about patients at that appointment. Sorry, yeah. For which part? This one? So we randomize the patients in a clinic. Yeah, individual patient. Yeah. So for this one, we are because not everyone will have smartphone apps, and this is not such a mature approach yet. We are doing it at few clinics, whereas the medication monitoring we are doing at a database level as opposed to, so we recruit them all from database and we roll it out in each clinic. One of the secondary benefit of this approach is it's creating a new digital care model, and it's creating an integrated, when we implement these two platforms, we end up creating an integrated data set that brings together hospital data with medications data with symptomatic data. So in this model, there are three unique characteristics. The data integration is happening in real time as opposed to traditional epidemiological studies. It's a digital cohort. And the tools are helping services provide interventions and the coverage on a needs basis. And more importantly, the longitudinal data that's created here could also become outcome measures to audit various policies and practice change. So that's the secondary benefit of taking this approach of using EHRs to recruit and implement these within EHR-identified populations. So that's basically the end of what I had to say. So in a nutshell, there's a lot of work to be done. There are a lot of optimization challenges in all of these. And as you can see, all these problems we have here, the problems of diagnosis, problems of engagement with therapy, or also the problems of how do we triage the right level of care at the right time. These are the problems that the mental health sector has, and these problems are because they use a one-size-fits-all approach to management. And the only way we can solve this is through digital systems, and these are more of an optimization issues. And I think there will be a lot of work to do from a methodological point of view in this space. I'll leave you with this quote from Tom Insel, who is the NIMH director. I like how he says where the psychiatry is heading. Thank you. Mm. Yes. 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 Yeah. Yeah. Yes. Yes. Yes, I think that's a very interesting point, and that's something I've been thinking of as well. The amount of background notifications that people are receiving in turn moderate how much are they likely to engage or not. Now, we can quantify that perhaps in some ways, but that would require getting additional permission from users. And if we can do that, then we can start factoring that in. But at the moment, it is quite challenging to collect that. So another way to look at this is we can't actually control this. We can't actually control what type of apps people will have on their phone, how many notifications they have. So taking into account all those potential variations that could happen, can we still engage with them? And what is the best time to engage with them? And this is where I think the micro-randomized trials are amazing, because they can factor all that in and still try to help us find a signal. And it might turn out that for some groups, you might actually not find any space where they will engage, because there is so much background noise. And that's a useful insight too, because then we may be able to develop more targeted strategies for that type of user profile. Susan might have something to say. Yeah.
Really roll it out. What is your overall plan for how this can happen? Because I mean, your team can't manage, doesn't want to maintain 500 apps for Australia.
Yeah.
So what's your plan for trying to make sure it gets into practice and that it's maintained in an appropriate way?
Yep. We try not to build and maintain these engineering infrastructure within our lab. And if we do, we try to get those out quickly. So like, for example, the 2 platforms we have, so we have a project underway right now where there are plans to spin that out into a company as well. The AI² platform in mind. The MindTick is already, we work with GoAct, who have a commercial phase to it. So with tech infrastructure, we try to work with companies that already have an interest in this, or figure out a way to embed them in. Yes, yeah. Personally, I think for digital health researchers and mHealth researchers in general, thinking about the end use, where this will end up, before we even think about what we are doing, is a good way to start. And because that solves 2 problems. One is you can translate, but more importantly, it also might change the research question a little bit. Because what seems like an interesting question might turn very not so feasible, not so useful when you take a cohort and ecosystem approach. And in Australia, there is actually a push towards research that's commercialized and translated now. So we had a major review of funding, NHMRC, that's our main funding body, like NIH. And in the evaluation criteria, they have put research impact as one of the criteria outside the publication. So you have to show what you have done to translate it. That's right. That's right. Yeah. Yeah. Yes. Yeah. Yeah. No, that's a good point. I guess what you're saying is the therapeutic alliance, the relationship with therapist or the main health professional has a bigger effect than the actual content, and that's I presume when you said nurse practitioners, it's those are not depressed patients. Are they heart disease patients? In psychotherapy, we don't have nurse practitioners, but there are nurse practitioners in chronic disease management programs. In CBT and the psychology space, there is that trust issue as well. They don't like discussing what very much. There is a lot of intimate issues that they have to open up with a therapist. So putting in another person who they haven't established that trust could be challenging. But the biggest predictor for outcomes in CBT treatments is actually quality of therapist, not the content. So that relationship they establish, that trust they build, is what is the medium that pushes the action from patient point of view. And so it's an interesting question to ask from a mHealth point of view. How do we recreate that therapist characteristics? And I don't think we're going to recreate that by pushing more content or tailoring more content. It has to go a bit more than that. Because it's not the content that motivates, it's the... That's right, the way the content is delivered, yes. Yeah.
Open up to a digital device as opposed to their therapist.
Yes. The other way, yeah, quite possible. But at the same time, if they don't feel they can trust their therapist, why would they even go to them, right? Yeah. 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 Yeah, I like the role of case managers in some ways for schizophrenia. This is similar to nurse practitioners. So they act as like the gatekeepers. They help people. These people can. Yes. Yes. So yeah, that's right. So that's right. Yeah. Yeah. No, I agree. I think there is plenty of potentials there. Especially since the coverage is a challenge, these case managers can't actually reach everyone. So the first one, the two, yes, yeah.
So how do you go about producing outputs where you recommend that really to the library?
Yeah.
Suppose there's some assessment that goes into them. And how are you connecting them? Are you committed to
yeah, so
to analyze
yeah, so yeah. Yeah. Yeah, so that toolbox that I showed earlier, that was done over 3 years. That was a large project which had different aspects to it. So in the first step we did with that project it was a well-being intervention. We wanted to help young adults use apps to maintain their mental health and well-being. So we did a range of user studies with the 13 to 24-year-old group. We looked at 16 plus because of the consent issues. We took the various psychological constructs of well-being, and which only a psychologist would understand, and a young person would not understand those constructs. So we came up with user studies to test those constructs with them. How do they conceptualize well-being? What does well-being mean to them? What are the type of actions they take when they are to improve their well-being? When do they act on well-being? So these are the things we try to tease out through these user studies. There's a paper on that as well. And from that we learned actually that one app is not good enough for solving mental health problems, because In this cohort, they describe mental health as sleep problem. They describe the symptoms as mental health problems. They don't describe it in a more diagnostic way that I have depression. They say, I'll do this when I have sleep problems. I'll do this when I have poor mood. So that gave us an idea and design ideas. So we can't offer people one app. We need to offer them solutions for each of those problems. So we came up with the concept of toolbox. Then we wanted to develop apps for those problems. And there were just too many problems. So it was just not a good idea to develop. Plus, there are 10,000 apps. And a lot of these apps are of dubious quality as well. They don't work. They're glitchy. Some are even recommending things that could be harmful. So we wanted to solve that problem. So there we focused on synthesizing the content in the apps. We worked with another group in Australia who they developed these appraisal processes. There is one called Mobile Application Ratings, MARS. Yeah. But there are other ways too. Susan Michie has those behavior change, BCT coding techniques. So using a range of such content auditing tools and a group of expert psychologists, we shortlisted app and we picked a few, and then the psychologists rated them. But that's the expert opinion on what is a good app. But we also wanted to take a user opinion on what is a good app, because users like engagement features. So we asked users as well to rate them on aesthetics, usability, and so on. So we combined all of that into a process to rate an app both based on expert as well as user. And from that, we came up with around 40 apps, which were part of the original test. And now the ongoing process is reach out, which whose aim is to reach this group. They have people within their services who follow this process and keep it up to date. So the end product is very simple. It's a website which is recommending you apps for some problems, but the process to get there was quite extensive. Does that answer your question? Yeah. Cheers. Thank you.